Please confirm if the slide is visible and audible. Yes. Okay. Right. Thank you. So, so today's session is nothing but a set of a bunch of PYQs. Okay, they are all case-based PYQs because in our exams, there are a lot of clinical case-based questions that have been asked with so much of split questions, sub questions. So those things you can attempt only when you analyze and read, apply and read your concepts. So only then you can attempt it correctly. And that has an advantage. What advantage does those sub questions have? Yes, it is advantageous because you can actually just get full 5 marks. If it is a short note and you get 5 questions, just if you are to the point, you will get full 5 marks, right? So whereas in a non-specific topic, only a topic is given as a short note, some points you may miss, or you may not even know what points to include, what not. So maybe the maximum marks that you can get will be 4.5 or 4. But in this case, if you get 5 sub questions from a case, you will get 5 solid marks, right? So that's the advantage of having sub questions. So in this session, in a series of sessions, I will cover many clinical case based questions. Most are all PYQs only, all your previous year questions. So it will be very useful for you all, right? So yes, so we'll start with the session. So the first question is the case number 1. Just read it along with me. I have sent you the PDF. You can just see the PDF also. So along with the answers, I have just consolidated all the answers in just 1 or 2 slides so that last minute before the exams, you can just revise and go. So surely I will tell you, surely you will get questions from these. All right. So let's start. So the first thing is a 6-year-old boy presents with periodic aggressive behavior. If my voice is not audible, please let me know on the chat box, right? And his urinary ALA is elevated. On examination, he is jaundiced also. And he has mild hepatomegaly. And blood examination reveals massive elevation of alpha fetoprotein. And HPLC or tandem mass spectroscopy, when you do, there was elevation in succinyl acetone, right? And a diagnosis of type 1 tyrosinemia is made. So most of the questions they had asked as clinical case based, they had actually given you the diagnosis. All right. So if they have given you the diagnosis, then it's pretty simple for you. You need not break your head in diagnosing it. But what you need to know is these topics you have to learn the theory part, right? Yes. So let's see. This is a case of type 1 tyrosinemia. So what is the probable enzyme defect here? Yes, you can just keep posting in the chat box also. What is the most probable enzyme defect here? The most probable enzyme defect would be fumarate acetoacetate hydrolase. Is it not? Fumarate? Yes, fumaryl acetoacetate hydrolase. Now, why does it present with elevation of ALA and neuropsychiatric manifestations? Very good. So very good. So you just keep posting the answers. I am seeing it, right? Yes. So fumaryl acetoacetate hydrolase is the enzyme defect. And why does he present with elevation of ALA and neuropsychiatric manifestation? Yes, because you need to know there is accumulation of succinyl acetone that also they have given you. Is it not? Now, what does this succinyl acetone do? This is structurally similar to, yes, this is structurally similar to ALA. All right. So, what does it do? It induces the ALA dehydratase enzyme. Yes. So, as it induces, it can mimic porphyria. Yes, induces, it mimics porphyria. So that is the reason that why he presents with elevation of ALA. So since there is more ALA and more neuropsychiatric manifestation. Why? Because if ALA is elevated, what will happen? If ALA is elevated, what will happen? it causes neuro manifestations. Okay, neuro manifestations like anxiety. Yes, so hallucinations. So psychiatric manifestations are more prominent in case of in elevated levels of ALA, and that is because of accumulation of succinyl acetone. And from where does this succinyl acetone comes from? It comes from, the enzyme that is defective is fumaryl acetoacetate hydrolase, and that will elevate the level of fumaryl acetoacetate in your blood. So that will lead to more production of succinyl acetone. All right. So this is what is happening here in this case of type 1 tyrosinemia. All right. Now describe in detail all the tyrosine metabolism disorders. So you need to just write down the pathway of tyrosine metabolism and then and there mark what disorder it is having. All right. So first let us see, the first thing is from phenylalanine you get tyrosine. Is it not? And from tyrosine you get 4-hydroxyphenylpyruvate with the help of the enzyme tyrosine aminotransferase. From here you get homogentisate, and that is because of the enzyme hydroxyphenylpyruvate dioxygenase, right? And homogentisate to mallyl acetoacetate by the enzyme homogentisate oxidase. And again from mallyl acetoacetate to fumaryl acetoacetate, and fumaryl acetoacetate gives you fumarate and acetoacetate. Yes, so this is the pathway. And what is type 1 tyrosinemia? Type 1 tyrosinemia is due to the deficiency of fumaryl acetoacetate hydrolase. And this is a hepatorenal tyrosinemia. Yes, this is a hepatorenal tyrosinemia. So you will find elevated AFP here. Yes, so in this case they have given us elevated alpha fetoprotein AFP, is it not? So that is a hepatorenal tyrosinemia. And what is type 2 tyrosinemia? Type 2 tyrosinemia is nothing but deficiency of tyrosine aminotransferase, and that is an oculocutaneous tyrosinemia, right? And type 3 tyrosinemia is what? It is neonatal tyrosinemia. Yes, transient tyrosinemia of newborn, and that is due to deficiency of hydroxyphenylpyruvate dioxygenase. When there is a gain of function mutation of this gene, then you call it Hawkinsonuria, right? And the main important disorder is alkaptonuria. And what is alkaptonuria? Alkaptonuria is due to homogentisate oxidase deficiency, right? And what are the different manifestations of alkaptonuria? Yes, what increases? Homogentisate levels increases, or homogentisic oxidase acid levels increases. That will get oxidized and it will form benzoquinone acetate. Yes, it will form benzoquinone acetate. Yes, and that is responsible for the blackening of urine, of course, when urine or your blackening of urine on standing. It's a classical feature of alkaptonuria. Is it not? Yes, very good. So this causes blackening of urine, and not just blackening of urine. What else does it cause? It causes alkaptone bodies. Yes, alkaptone bodies, and it gets deposited in your pinna. Yes, it gets deposited in your pinna, IV discs, IV vertebral disc, no, intervertebral disc. That will lead on to what is called as ochronosis. Yes, you need to understand these points here. So this is all about your alkaptonuria. And also you have another, yes, and also you have another disorder. What is albinism due to? Yes, what is albinism due to? Tyrosine. Yes, tyrosine to melanin. So what is another product of tyrosine? It is melanin. So when this enzyme, tyrosinase is defective, it leads to albinism. When there is deficiency of tyrosinase, yes, very good, it leads to albinism, right? And again, tyrosine also gives you what? Catecholamines. It gives you catecholamines, is it not? So elevation of catecholamine producing tumor is what? It is pheochromocytoma. Yes, it is pheochromocytoma. And what should you remember with this pheochromocytoma? It's a catecholamine producing tumor, and there is increased VMA here. Yes, because the end product of the metabolized product of the epinephrine, it gets broken down to form vanillyl mandelic acid. And also you will find increased plasma metanephrin in this case. All right, so this is about your pheochromocytoma. All right, and what is another product of tyrosine? It is thyroxine. That is your the chain has been iodinated. The tyrosine residues of in the thyroglobulin, the tyrosine residues are being iodinated, and that forms thyroxine. Right. So that is another product of tyrosine. And also the already as we have seen, we have fumarate and acetoacetate as the end product, and that is why you call tyrosine as a both glucogenic and ketogenic amino acid. And phenylalanine is a precursor of tyrosine. So phenylalanine and tyrosine both are glucogenic and ketogenic amino acids. All right. So these are the products again. So products only they have asked. Add a note on the special products formed from tyrosine, that also we have seen. Catecholamines, then melanin, thyroxine. All right. Yes. So this is about your tyrosine metabolism. So this is how you have to understand it. So just focus on these points when learning this tyrosine disorders, right? Yes. So let's move on to the second case. Second case, it's a 5-year-old boy. He's brought to the hospital with complaints of mental retardation, hypopigmented patches all over the body, and mousy odor of urine. So it's very easy, is it not? Mousy odor of the body fluids. If you have this term, then it is definitely going to be phenylketonuria. So what is the most probable diagnosis? It is phenylketonuria. And what is the enzyme defective here? The enzyme defective is going to be your phenylalanine hydrolase or hydroxylase. Yes, what is the enzyme defective here? It is going to be phenylalanine hydroxylase. Tyrosinase, tyrosinemia. Yes, tyrosinemia type 1 is fumaryl acetoacetate hydrolase, whereas phenylketonuria is deficiency of phenylalanine hydroxylase. Yes, so we have types in this phenylketonuria. So type 1 is nothing but the classical type. This classical type is nothing but the deficiency of phenylalanine hydroxylase. And you have type 2 and type 3, which is due to deficiency of dihydrobiopterin reductase enzyme. Okay, that is another coenzyme, that is another enzyme which is necessary for the cofactor dihydrobiopterin, is it not? So you have the dihydrobiopterin reductase deficiency, right? And you have type 4 and 5, which is due to the deficiency of enzyme that synthesizes biopterin. All right, so these are the types of phenylketonurias, right? But the classical most common is nothing but your phenylalanine hydroxylase. So that you have to definitely know. And biochemical basis of clinical features seen in this boy. So what can be the biochemical features? What are the features which are given here? Mental retardation is given, hypopigmented patches are given, mousy odor of urine is given. So what are the manifestations? What are the bases of those? So phenylalanine to tyrosine is catalyzed by the enzyme phenylalanine hydroxylase, and that is what is defective. Yes, that is what is defective here. Now this since phenylalanine hydroxylase is defective, your phenylalanine is going to get elevated. It is going to get accumulated in the circulation. So enhanced phenylalanine levels will now get converted to phenylpyruvate, phenyllactate, phenylacetate. Is it not? So by various enzymes, transamination reaction or reduction reaction or decarboxylation reaction, it is going to produce phenylpyruvate, phenyllactate, phenylacetate. What are all these? These are your phenylketones, is it not? These are your phenylketones. So these phenylketones are responsible for the mousy odor of your body fluids, right? Not just urine, in the sweat even. So in the sweat also will lead to mousy body odor, right? Yes, so this is because of your phenylpyruvate excess in the circulation. Now, there is mental retardation, that is also because of the accumulation of these phenylketones. And there is agitation, hyperactivity, seizures, convulsions, and nothing but your seizures, tremors are all there. And why is there hypopigmentation? Because from phenylalanine, we have seen already, phenylalanine gives tyrosine, tyrosine gives melanin. And since the tyrosine levels are less, melanin levels are less, that's why you have hypopigmentation in these individuals, right? So due to decreased availability of tyrosine here. So these are the manifestations of phenylketonuria. So this is also another important question, right? So from tyrosinemia or phenylketonuria, you will be definitely getting a question. All right. So please learn that. The next case. The next case is 21-year-old woman who recently began taking birth control pills, presents to the emergency room with cramping abdominal pain, anxiety, paranoia, hallucinations. Surgical evaluation was also done, including ultrasound and computed tomography, fails to demonstrate an acute abdominal process. So the abdominal pain was so much that they even started evaluating something related to abdomen cause, acute abdomen cause, right? And urine analysis reveals an increase in the urine ALA and PBG. All right. So this is what is the case say. So what is your probable diagnosis? Yes, tell me what is your probable diagnosis? What is your probable diagnosis? Whenever you find just elevation of ALA and PBG, and that gives you, how do you just write out your symptoms here? There is urine ALA PBG elevator. Yes. And you have neuropsychiatric symptoms. Neuropsychiatric symptoms like anxiety, hallucination, paranoia, and also you have acute abdomen. Yes, acute abdomen that they just went into the even for surgical exploration. In some cases, they will even do emergency laparotomy. It will be that much present like an acute abdomen. Okay, so when you just narrow down to these 3 points, you can just very well say, yes, very good, it is acute intermittent porphyria. That's the probable diagnosis. Now, what's the enzyme deficient here? The enzyme deficient here is going to be your porphobilinogen deaminase. Yes. So you have even other name UPG1 or uroporphyrinogen 1 synthase. Yes. So this is the enzyme deficiency that leads to acute intermittent porphyria, and this is the most common type of porphyria. So whenever you find any case related to porphyria, just think about AIP in the first place. Yes, most commonly that only will be asked. We also have another case, but that will also have classical symptoms that I will tell you. But otherwise, if you narrow down to these 3 points like increase ALA, neuropsychiatric symptoms and acute abdomen, it is very well going to be your AIP. Now explain in detail the metabolic pathway that's defective in this patient. Yes, what is the metabolic pathway defective? It's going to be heme synthesis only. So heme synthesis, the first thing is, what's the substrate for heme synthesis? It's glycine and succinyl-CoA. Glycine and succinyl-CoA gives us ALA in the presence of enzyme ALA synthase. So what are the 2 organelles in this pathway is going to occur? It will occur both in the mitochondria and in the cytosol. All right. And the next is the substrate, glycine and succinyl-CoA. That first step happens inside the mitochondria. After which the ALA leaves the mitochondria. All of the other, 3 more steps happens outside in the cytoplasm. Now ALA to porphobilinogen with the help of the enzyme ALA dehydratase. What is the speciality of this ALA dehydratase? The point that you should remember, lead poisoning. Yes, lead poisoning inhibits this enzyme, right? And porphobilinogen, and then you get uroporphyrinogen 3 and then coproporphyrinogen 3. Yes, that's with the help of the enzyme uroporphyrinogen decarboxylase. And this PBG deaminase is what? AIP. And UPG3 co-synthase is what? It is the deficiency of this enzyme will cause congenital erythropoietic porphyria. Right? Again, we will come to the disorders. So again, now coproporphyrinogen 3 will now enter into your mitochondria again, and with the help of series of enzymes, you get protoporphyrinogen 3, protoporphyrin 3. Finally, you get heme. So in protoporphyrin 3 combines with iron to form heme. Yes, remember this. So this you need to remember. And what is the other thing that you should remember in case of ferrochelatase? That is also inhibited by your lead poisoning. Yes, it's also inhibited by your lead poisoning. All right. And what's the specialty of heme again? Heme, it's a regulator of this pathway. Yes. That feedback inhibits your ALA synthase enzyme. That is why this pathway finally ends in the mind, starts in mitochondria, ends in mitochondria, so that heme is available in mitochondria to inhibit the ALA synthase, and ALA synthase is going to be your rate limiting step. Yes, ALA synthase is going to be your rate limiting step here. Is it clear, all of you? Yes. So this is about the pathway. Now let's see what is the next question. So this is done. What is the biochemical basis of the clinical features? So what clinical features do we have? We have neuropsychiatric manifestations and abdominal features, is it not? So what is the basis of this? So just come to this box. Here, I have given you the basis of all the porphyrias. So basically, the first thing is you can have neuropsychiatric abdominal symptoms, or you can have photosensitivity symptoms in case of porphyrias. Is it not? Only these two. So the abnormalities of heme enzymes, that is mainly due to in this pathway, if suppose this PBG deaminase is defective, what happens? Porphobilinogen ALA gets accumulated, and our manifestations are mainly dependent or mainly due to the accumulation of the precursors. It is not because I do not have uroporphyrinogen 3 that my symptoms are appear, is it not? It is because of accumulation of these it is because of the accumulation of the intermediates above the enzyme deficient level. Because of the accumulation only, I am getting symptoms. So that's the first point that you need to remember. So accumulation of ALA and PBG and decrease in the heme, that will lead on to your neuropsychiatric symptoms. So ALA, PBG always affects your neurological side. And then accumulation of porphyrinogens. So porphyrinogens in skin, porphyrinogen levels, if it gets elevated in your circulation, it will run in your capillaries. Whenever it is, photo oxidized, it will get converted to porphyrins. Yes, so that porphyrins is what is responsible for formation of, responsible for causing photosensitivity. There's dermatitis, photosensitivity, scarring. All these are because of your porphyrinogens. So severe porphyrinogens, those porphyrinogens get spontaneously oxidized to porphyrins, and that porphyrins is going to cause photosensitivity. Skin manifestations, cutaneous manifestations. All right. So this is the biochemical basis of your clinical features here. Now give reasons for the development of symptoms after taking birth control pills. So what is the reason for this? Porphyria, there are precipitating factors. So not just the birth control pills, just remember all these. So whenever you find all these factors in your case, yes, the main reason is they all induce your enzymes. They all induce the enzymes of heme synthesis. All right. So female hormones, so they will predispose to the, already the patient is deficient in any heme synthesis pathway enzyme, and they're already having porphyric symptoms. In this again, these factors can actually precipitate the porphyria. That's what you have to remember. So female hormones, menstrual cycle, of course. So before menarche or after menopause, the symptoms are less. Okay, so in between these two periods, the symptoms are both. That's because of the precipitating effect of your female hormones, menstrual cycle, and drugs like your barbiturates, progestogens, anticonvulsants. So here in OCPs, birth control pills or oral contraceptive pills, the main content is going to be your progestogens, right? So the presence of that will increase the risk for porphyria. And low carbohydrate diet, fasting is going to cause it is going to increase the risk for porphyria. So that's why in acute intermittent porphyria treatment, we give glucose. Yes, we give glucose. Yes, then infection and stress. That is going to limit ALA synthase, and the pathway itself will get suppressed, and that will help in the treatment, acute management of porphyria. That's why we give glucose and hemin in case of porphyrias, right? So this is about your porphyria. So porphyria is very, very important. Acute intermittent porphyria is most common, and it has the maximum chance of being asked, right? The next case is also porphyria. Here again, they have given you the diagnosis. Let's just read the case. A 3-year-old male child, blisters on exposed areas since the age of 6 months. No, the blisters used to heal and then it will produce scar, right? And the mother had noticed reddish colored urine, port wine urine, right? And the mental physical development had been normal. There was no family history of similar problem. The child's face was badly scarred. So exposed area, you have so much of photosensitive reactions, many blisters that heal, form scars. So the face forms there is a monkey face that's been formed. And there was hypertrichosis on the shoulders, arms, and face. Teeth were of coppery red color. So what is the diagnosis here? It is congenital erythropoietic porphyria. Now, what is the enzyme deficient? Yes, tell me what is the enzyme deficient here? What is the enzyme deficient? Just now we saw, is it not? Just now we saw UPG3 co-synthase. Yes, that's what is the deficient enzyme. Yes, very good. UPG3 co-synthase. Now, what's the biochemical basis of congenital erythropoietic porphyria presenting with erythrodontia? What is erythrodontia here? It is the red color heat that is seen. So, whenever the UV light is getting exposed to UV light, red fluorescence is being observed. Yes, very good. It's UPG3 co-synthase. And also you observe port wine urine. So urine on standing, it gets auto-oxidized, or photo-oxidized, and it produces a different color. Yes. So this is the basis. So let's just see what is that. There is accumulation of porphyrins. Why is there accumulation of porphyrins again? You must know the pathway here. So here when UPG3 co-synthase is affected, what will happen? Let me just write here. So what will happen? From ALA you get PBG. Yes, from PBG you get PBG is porphobilinogen, is it not? And then hydroxymethylbilane, and from hydroxymethylbilane you get uroporphyrinogen 3. And uroporphyrinogen 3 isomer is only maximum that will only get converted to other porphyrinogens in the pathway. But it also gives another isomer which is uroporphyrinogen 1. So the conversion of HMB to UPG3 is what is UPG3 co-synthase. So what happens when this enzyme is defective? Yes, what happens when this enzyme is defective? Yes, HMB will get accumulated and UPG1 isomer gets elevated in the circulation. Yes, so uroporphyrinogen 1 isomer is going to get elevated and those uroporphyrinogens will get converted to its corresponding porphyrins and that corresponding porphyrins will again lead on to photosensitive symptoms and this is not feedback regulated. Okay, that's why that is the reason for the severity of symptoms in this case. So this is not feedback regulated. That's what you have to understand. All right. So here again, just why is there photosensitivity? The porphyrinogens will get auto-oxidized to their corresponding porphyrins and they will cause photosensitivity when they're exposed to visible light of about 400 nanometer wavelength. So this is also possible. So this is a result of their excitation and reaction with the molecular oxygen that leads to production of the radicals. Okay, so the resulting radicals will injure your organelles inside the cell and that will lead on to release of those lysosomal degradative enzymes and that is responsible for the various skin damage including scarring. So this is the reason for your photosensitive or cutaneous manifestations and scarring. All right. Yes. So again, the same thing has been given in congenital erythropoietic porphyria. What is the thing that I told you? UPG1 isomer is going to get elevated. So that will get converted to its corresponding uroporphyrinogen 1. This is not feedback regulated. So it will just get increased in your capillary. So on exposure to light, what will happen? The reactive oxygen species are getting elevated. They will cause cellular destruction. Right? When UV light is reflected onto teeth, as I said before, it will cause red fluorescence and that's what is erythrodontia. Right. So repeated attacks of this. No, in this case, from the 6 months of age, the child is being exposed. So repeated attacks of this will lead to dermatitis and scarring, and that's why there is a facial deformity. Typically, it's referred to as monkey face. So repeated ulceration, scarring will lead on to mutilation of your nose, ear, cartilage. It will even mimic leprosy. It's that severe. Right? Yes. So this is about your ALA. Yes, this is about your erythrodontia, port wine urine. Yes, port wine urine also is the same thing that I had mentioned earlier, where the urine on standing, it gets, gets photo oxidized, so it becomes your porphyrins are elevated, so that when reflected in light, it will give you the red color. That's port wine urine. Now, will ALA and PBG elevate in this condition? Yes. Will it elevate in this condition? Yes, of course it will get elevated. If you look into the pathway, HMB is elevated. ALA PBG can also get elevated, but mostly this pathway is more severe. Mostly UPG1 pathway is more severe, but of course, since this intermediate is there, the above precursor intermediates can also get accumulated. All right. Yes. So the next question is, what are the differences between AIP and congenital erythropoietic porphyria? So now that we have learned both, now that you have just tell me what is the enzyme defect in both, the enzyme defect in AIP is going to be PBG deaminase, right? And the enzyme defect in CEP is going to be UPG3 co-synthase. Yes. And what is the main manifestation of AAP? It is going to be acute abdomen plus neuropsychiatric symptoms. There is no cutaneous features because porphyrins are not being accumulated here. So there is no cutaneous manifestation, but cutaneous manifestation is the main feature here. Photosensitivity, monkey face, scarring. Yes, erythrodontia. So erythrodontia is here. Port wine urine is there. But so this is a difference between your AIP and CEP, right? AIP and CEP. And what is getting elevated here? ALA and PBG are the main things that get elevated. In CEP, congenital erythropoietic porphyria, your uroporphyrinogen 1 isomer is getting elevated. So this is the majority that is causing the manifestation that I'm telling you, right? So this is the difference between your acute intermittent porphyria and congenital erythropoietic porphyria. And the next question is, what are the effect of lead poisoning on heme synthesis? So already I had told you two enzymes that have been inhibited by lead poisoning. What are they? ALA dehydratase and your ferrochelatase. All right. So this is the effect of lead poisoning on heme synthesis. All right. So this question, though it looks big, does it look difficult now? No, is it not? It's because you just learn points. So much is given in your book. I want you to pick up points and write. Okay. Write it in a separate, note or stick notes that you can have, and just write down only few points. What is the enzyme defect? What is the main feature? What is the investigations with which you will find out what kind of porphyria it is? What is the pathway? So main points alone, you just narrow it down so that you can read it for your exams. All right. Yes. So let's move on to the fifth case now. A 4-year-old girl was brought to OPD for not being able to walk properly. It's again another easy question, but very important question. You will definitely get this in your exams. All right. Yes. She had bowed legs, thick wrists, dental caries. Her weight, height were below third percentile. X-ray shows cupping, widening of metaphyseal end of the bone, poor bone mineralization, and lab investigations showed serum calcium 8.5. So what is the normal calcium levels? It will be 8.5 to 10.5 gram per milligram per deciliter. So it's kind of normal. And serum phosphorus, remember, it's similar to albumin only. This is, low normal you can have. And serum alkaline phosphatase is 924. it should be around 40 to 150, but it is elevated here, much elevated. Even if it is a 4-year-old child, it is too much, it is elevated here. And serum 25 hydroxy vitamin D is the most common vitamin D that we measure for vitamin deficiencies. That is 12 nanogram per ml. So what's the normal range? Usually they give you the normal range, but sometimes they don't. So other calcium, phosphorus, alkaline phosphatase and all that, I know you know, because you will learn. But for vitamin D, it is more than 30 nanogram per ml is only the normal range. So here it is deficient. Yes. So with the help of this symptoms only, you will be able to find it is vitamin D deficiency. So since it's a child, then what will be your diagnosis? The diagnosis is nothing but your rickets. Now write the daily requirements about all about your vitamins you have to learn here. Daily requirements, sources, and its main functions that you need to know. So what's the daily requirement? Yes, for children it's 600, for infants it's 400, for adults and in pregnancy and all that it is 600 units per day. Yes, so when there is increased demand or when you're treating osteoporosis and all, you can give up to 800 units per day. Right, so this is RDA that you can learn. And what are the sources? The main source is sunlight. Yes, the main source is sunlight. And you can have the non-vegetarian sources like your fish liver, oil, fish and egg yolk are good sources. Milk will contain moderate quantity. Fortified products. We have food products that are fortified with vitamin D. So that also, an exposure like they say before 10 or after 3 at least 15 minutes a day, that's been given in the textbook. So this is about your sources of vitamin D. Yes, the main source is exposure to sunlight. So that we are done with the daily requirement. And write in detail about the deficiency manifestation in children and adults. So what's the deficiency manifestation in children and adults? In children, it is going to be rickets. In adults, it is going to be osteomalacia, right? So in children, what will happen here? In rickets, what are the different clinical features? That all you tell me. Yes, clinical features. There is insufficient mineralization of bone. So you will have bowing of legs. When the child starts weight bearing, it starts walking, and you will find bowing of legs here. So the bones will become soft and pliable. Bone growth is affected. So the weight bearing bones are bent. So you will find bowed legs, knock knees, rickety rosary, and bossing of frontal bones and pigeon chest. Right, so these we have been learning for so many years, so we will definitely know. So this is the bowing of legs. Yes, and this is the x-ray feature that is showing you enlarged epiphysis. Yes, so it's showing you enlarged epiphysis, and this is the rachitic rosary, right, and onycholysis of nails. So these are the features. So other features you can see Harrison sulcus, rachitic rosary, reduced bone mass, enlarged epiphysis, knock knees, bowed legs, all these in children that you find. In adults, again, you find organ damage also, right? And then you have muscle weakness, all that muscle pain, bone pain, osteoporosis, liver disease, all these you will have, because of which you will have the vitamin deficiency. Yes. So what again, next, the important thing that you should remember is the blood investigations. You will find normal plasma calcium and phosphorus. Okay, you may find, but it can be low also, but if it is normal also, you shouldn't. The vitamin D is only going to give us the correct value. Why is it? Because you have secondary hyperparathyroidism, which is going to help us in correcting the calcium levels, right? So that is why. And you have alkaline phosphatase, which is markedly elevated. So that you must remember. Alkaline phosphatase is markedly elevated. All right. Yes. So this is about your investigations. And if you can see, yes. So this is what is the adults and the rickets in children. Now, adults, when you see there is osteomalacia, the bones will soften, insufficient mineralization, and there is increased osteoporosis. So osteoporosis is a feature in adults, all right, and they are more prone to get fractures. Onycholysis may be seen in nails in adults, right? So here again you will find low serum calcium, low serum phosphate. They're only slightly lower, right? And it never produces severe hypocalcemia. So this is the point that I want to stress. So vitamin D deficiency never produces severe hypocalcemia. All right. Tetany will not be manifested in case of vitamin D deficiency. So that you must know. In case you have tetany, it is due to other causes, parathyroid causes maybe, or it is not due, or maybe even alkalosis, but not due to vitamin D deficiency alone. Okay, you should have another cause to find tetany in any patient. And serum alkaline phosphatase, it's a bone formation marker, no? So that is also increased. That will be increased in case of this because there is osteoporosis. So the bone remodeling process is just taking place, but not that efficient. But since it's taking place, it is producing more of alkaline phosphatase, which is produced from the osteoblasts. Okay, so these are the two main manifestations that have been asked in the question. Yes, so we have done with the deficiency manifestation and what are the causes of this disease. Yes, what are the causes of this disease? It's very easy, of course. They are not exposed to sunlight properly, right? And then the nutritional deficiency, there is a malabsorption of vitamin, maybe due to obstructive jaundice. Yes, even this because it is a fat soluble vitamin, A, D, E, K, or all fat soluble vitamins. So they will get absorbed through the diet. If it has to get absorbed, they will be absorbed along with the fat. And liver disorders and renal disorders. So that will also retard the formation of vitamin, activation and formation synthesis of the active vitamin D. So that is also the cause of this. And deficient reabsorption, renal reabsorption of phosphate. So these may be the causes of vitamin D deficiencies. Yes. So this is about your vitamin D deficiency. Let's move on to the next case. Yes, let's move on to the next case. So the 6-month-old infant presented with failure to thrive. This is again vitamin D, but look at whatever details we have left there has been asked here, right? So failure to thrive based on deviation from two major percentiles on standard growth curves. Yes. And serum calcium level is normal. See, now here the serum calcium level is normal they have given. Is it not? Phosphorus and vitamin D levels are very low. Alkaline phosphatase and parathormone levels are very high, right? So what is the take home point? In case of vitamin D deficiency, you can have normal calcium phosphorus, right? But you will have elevated ALP and elevated PTH and very low vitamin D, of course, because it is nutritional or vitamin D deficiency rickets. All right. So this is a 6-month-old infant. Okay, so weight bearing features like your boat legs, knock knees will not get manifested here, right? So in that case, you have to, with the help of failure to thrive only, you have to investigate. Now, why does vitamin D deficiency cause an elevated PTH and ALP? So you know this already. Let me tell you again. Let's start with activation. So first thing is either through skin or through dietary, the vitamin D3. Through skin, it's vitamin D3. Dietary or some supplements will have vitamin D2. So both of which are entering into your circulation. It is going to the liver. In liver, with the help of the enzyme 25 hydroxylase, you find 25 hydroxy D3 is being produced. And that goes to kidney, and with the help of the enzyme 1 alpha hydroxylase, 125 dihydroxy vitamin D is produced. And how does this act? It enters your cell with the help of vitamin D receptor. Vitamin D receptor again sits on vitamin D response elements, and then it brings about the transcription of proteins that that are going to execute the functions of vitamin D, right? So that is why you call vitamin D as a hormone. Why do you call vitamin D as a hormone? Because it has a hormone like action, right? It has a receptor, it binds to the receptor, it binds to the vitamin D response elements on your DNA, and that is going to bring about transcription of proteins that will execute the functions of your vitamin D, right? So that's why you call vitamin D as a hormone. Now, why in this case, what is the use of PTH? Yes. So whenever your vitamin D levels are less, what will happen? Whenever your vitamin D levels are less, it will lead to reduced calcium levels. Yes, because calcium absorption is being reduced from the intestines. So what will happen? Calcium absorption from intestine, calcium reabsorption from kidney, right? And also from the bone resorption from bones, that also, so all of which will cause hypercalcemia. It is going to increase the calcium level. The vitamin D function is to increase calcium level. That is not happening here. So what happens? There is decreased calcium levels, then that is being sensed by the calcium sensing receptor of the PTH, yes, of the parathyroid, and it produces parathyroid hormone, and parathyroid hormone in turn activates 1-alpha hydroxylase present in the kidney. Okay, 1-alpha hydroxylase present in the kidney, and thereby it is going to induce the production of vitamin D, and it corrects the calcium. And not just one, it can also act on the bone and cause bone resorption, and via causing bone resorption it can elevate the calcium levels. So that is one more function of parathyroid hormone, right? So what does parathyroid hormone do? Whenever there is reduced calcium, it is being sensed by the parathormone or the calcium sensing receptor of the parathyroid gland, and more of parathormone is being produced. And the function of parathormone is to induce 1-alpha hydroxylase in the kidney, and also to cause bone resorption, and it increases the calcium level. So, and it fixes or corrects the calcium levels in your circulation, right? So that is why your PTH or your parathormone gets elevated in case of vitamin D deficiency. And vitamin D is it causes bone mineralization, right? That is one of the functions of vitamin D. Now, whenever there is bone mineralization or bone remodeling, or in case of vitamin D deficiency, the bone remodeling is getting affected. So in that case, what will be produced? ALP is a marker of bone formation. So whenever it is getting resorbed more bone formation steps are also happening. So ALP as a marker of bone formation is produced from the osteoblast, that is getting elevated. That's why in vitamin D deficiency, you have elevated ALP. Alright, so these are the points that you have to remember. So what are the functions of vitamin D? It acts in 3 organs. What are they? Intestine, bone and kidney. In intestine, what does it do? It causes absorption of calcium and phosphorus. How does it bring about this action? Just see the picture. Calcitriol or the vitamin D enters, it forms the receptor, vitamin D receptor complex, and that will bind to the DNA, and it causes transcription of carbindin protein. Carbindin protein is responsible for for absorption of calcium from the lumen of the intestine, right? In this way, it will increase the absorption of calcium and phosphorus. In kidneys, what does it do? In kidneys, again, it causes reabsorption of both calcium and phosphorus. Whereas PTH only reabsorbs calcium, it does not reabsorb phosphorus. Remember that also. And mineralization, of course, we have seen it increases. There is bone remodeling. So vitamin D induces bone remodeling action of the osteoclast and osteoblast. So that's what you have to remember. Yes, so this is the function of your vitamin D. So vitamin D, I've put up 2 questions. Both are previous year questions. It has covered the entire vitamin D chapter only. So you have to learn that. It's very important, right? So how is vitamin, next question. So first question we have done. How is vitamin D activated? So activation is from the skin, 7-dehydroxycholesterol upon, sunlight exposure. So this is what is the vitamin D activation. And how does vitamin D regulate calcium and phosphorus levels? That also we have seen in intestine, bone and kidney. What is its action? So finally, it increases calcium and phosphorus in your circulation. That's what is the activity of your vitamin D, right? Yes. So let's move on to the next case. All right. So is it useful? Can we continue? Can we continue the session? We'll see 10 cases and then few MCQs, and then we'll have a separate session. Is that fine, or what do you feel? Yes. All right. So I will continue. So the next case is the next case is a 10-year-old boy had difficulty in vision at night, and his vision was quite normal during the daytime except when he entered a dimly lit room. Right? On investigations, plasma retinol levels are found to be low. So it's very straightforward. So what suggests the probable diagnosis? What's the diagnosis? It is night blindness. Yes, night blindness. You also call it as nyctalopia, is it not? So night blindness. What is the diagnosis? And nutrition that is deficient is of course vitamin A. So it's a pretty straightforward question. And what are the different functions? One is vision, and you have gene regulation, immune system regulation. It provides immunity. It has antioxidant property and reproductive property, and then if skin remodeling also it helps. And write a note on Wall's visual cycle. So that's what is important here. So here is the pigment. Here is the rods and cones, which has this protein rhodopsin. Rhodopsin is made of opsin and 11 cis retinal. So on this rhodopsin, whenever the light is fallen, there is photoisomerization that happens, and all there is a series of intermediates that is being formed like metarhodopsin. Yes, and then finally all trans retinal is formed. Now this all trans retinal goes to the retina. Yes, goes to the retina. It forms trans retinal. Here only with the help of the enzyme retinal isomerase, it can get converted to cis retinal, and it can form 11 cis retinol. All right, 11 cis retinal. Now here, or it can, the trans retinal can go to the blood. Via blood it can enter the liver with the help of the enzyme alcohol dehydrogenase. It forms trans retinol. Then it forms with the help of retinol isomerase, it forms retinol, and finally it gives you cis retinal. Yes, sorry, this is aldehyde dehydrogenase and this is alcohol dehydrogenase. All right. Now this cis retinal again gives you 11 cis retinal. So what is the purpose of this Wall's visual cycle? So this you can just memorize. It's very easy if you know what's the how is rhodopsin formed, and how does it get photoisomerized, and it's bringing back 11 cis retinal. So for what is the purpose of this Wall's visual cycle? Wall's visual cycle, the purpose of which is to regenerate. Yes, regenerate 11 cis retinal. So it can happen easily in the retina, or it can take a long route to the liver and to the 11 cis retinal. Yes, so that is what is the importance of this Wall's visual cycle. Yes, so this is just that. So if you just write, it's very easy. You have some questions. If you just know the diagnosis, vitamin A deficiency, 4 functions, and Wall's visual cycle, you will get solid 5 marks. It is as simple as that. Now let's move on to the next case. So here, inspired by Sylvester Stallone's rocky body, a 23-year-old male wants to build his muscle, and instructed by his trainer, he takes 6 raw eggs every day. So we know where this is going to lead us to. It is nothing but the avidin, which is inhibiting the biotin, and its biotin deficiency. That's what we would think here. But see, after 2 months, when he was working out, he suddenly passed out and his plasma glucose was 60 milligram per deciliter. After treating him, the physician advised him to refrain from having raw eggs, yes, obviously, and warned him that raw egg consumption causes low glucose. Yes, so you know the answer, but have you ever thought in this angle? That is what is the question. You know the answer because we have learnt about all about biotin. Biotin, what are the enzymes present in biotin? What are the enzymes for which biotin is a cofactor? All that we have learned, but we have not applied it, is it not? So let's just see. The first question is, why does raw egg consumption cause low glucose? For which I will just take you to the box that you have already learned. Yes, what is the coenzyme activity of biotin? Yes, it is a coenzyme for carboxylation reactions, is it not? And what different carboxylase enzymes require biotin? One is acetyl CoA carboxylase, propynyl CoA carboxylase, pyruvate carboxylase. What is this enzyme pyruvate carboxylase? It is an enzyme of gluconeogenesis. And what is it catalyzed? Pyruvate to oxaloacetate is being catalyzed. Oxaloacetate is a substrate of gluconeogenesis. Yes, so whenever there is avidin, it is going to inhibit the absorption of biotin. So there will be biotin deficiency. This will in turn inhibit pyruvate carboxylase. So that is why you find low glucose. All right, that's why you find low glucose. So this is just simple. This is the reason. What are the products of odd chain fatty acid oxidation? Again, what is the link between this biotin deficiency and odd chain fatty acid oxidation? Yes, so you know propynyl CoA carboxylase has a cofactor which is biotin. Now let's come to the propynyl CoA. Odd chain fatty acids. What does it produce? Odd chain fatty acids. Yes, oxidation of odd chain fatty acids, it's going to be same as that of even chain fatty acid. But whenever the fatty acid undergo the beta oxidation, in every cycle it produces two carbon units. Is it not? So even in odd chain fatty acid, the same is going to happen. But at the end cycle, what will happen? You will get a 2 carbon and 1 3 carbon. And that 3 carbon is going to be your propyonyl CoA. Yes, yes, yes. So that 3 carbon is going to be a propynyl CoA. That's how propynyl CoA is being produced when odd chain fatty acids are oxidized. Now this propynyl CoA with the help of the enzyme propynyl CoA carboxylase, which has its cofactor as biotin, and it also needs ATP and CO2. So what does this carboxylase reaction need? It needs ABC. Yes, it needs ATP, it needs biotin, it needs carbon dioxide or bicarbonate. Yes. So this needs ATP. What needs ABC? Carboxylase, any carboxylase reaction. Yes. So this it produces 11 D-methylmalonyl CoA that again gets converted to L-methylmalonyl CoA. Then with the help of the mutase enzyme which needs B12 as its cofactor, and succinyl CoA is produced. Now this succinyl CoA again. Yes. Now this succinyl CoA again is a substrate of, it's an intermediate of TCA cycle, is it not? All intermediates of TCA cycle will be substrates of gluconeogenesis. Again, this is even if this is not absent, then the substrates for gluconeogenesis is reduced, and hence there can be low glucose. All right. So these are the two reasons why you can get low glucose. Yes, one is pyruvate carboxylase, the other one is propynyl CoA carboxylase. Now, what are the products of the odd chain fatty acid oxidation metabolized further? So that's what we have seen already. Methylmalonyl CoA and then succinyl CoA. Those are the products of oxidation of or metabolism of propynyl CoA. So that's very important. So odd chain fatty acid as such is actually very important. All right. So this is about your about that case, biotin deficiency. Now let's see the next case, which is a 26-year-old female presenting with history of anorexia, constipation, fatigue, poor memory, irritability, sleep disturbance, such a long history, bilateral, symmetrical, lower extremities, paresthesia with burning pain, muscle cramps. Where is it taking us? We don't know. On examination, there was decreased vibratory position sensation, absent knee and ankle jerk, muscle atrophy. Her diet consisted of polished rice without pulses and oil seeds. Enzyme transketolase level in RBC was low. Tell me the diagnosis. Yes, you should tell me the diagnosis. Yes, whoever is consistent till the end of this class is going to get benefited too much. Okay, because all are important questions. Your question paper will definitely have these questions. That's for damn sure. Right. What's the probable diagnosis is here? Yes. Yes, berry, very good. Very good that you mentioned berry. Okay, what type of berry is it? What are the types of berry? Can you tell me what type of beriberi based on? Because they have given a long history with, memory, irritability, sleep disturbance, paresthesia, vibratory position, knee jerk, ankle jerk, muscle atrophy. CNS symptoms they have given us. Yes, CNS symptoms. They have given us only CNS symptoms. So that is going to be dry beriberi. Yes. Yes, you have told me the types of beriberi, but what beriberi is this case? It's a case of dry beriberi. All right. So this is a case of dry beriberi because we have predominant CNS symptoms. Yes, good, all of you. Yes. So mention the cause for this condition. Of course, it is thiamine deficiency. Yes, as thiamine deficiency or the B1 deficiency. Yes. So name the sources. Why do you say it is B1 deficiency? And what is the cause? For this diet consisted of polished rice without pulses and oil seeds. Yes, very good. It is a probable diagnosis B1. So first, just see, aileron layer of the cereals is a rich source of thiamine. Yes, the outer layer of your cereals is going to be a rich source of thiamine. What happens when you take polished rice? So polished rice. Polished rice will remove the aileron layer. So in that case, what can happen? Polished rice will remove the aileron layer. So when anybody is going to just have the polished rice with no other alternate supplementation of thiamine in their diet in case of other like pulses, oil seeds, nothing they're taking, they're just taking polished rice only, then they will have thiamine deficiency. All right. So this is the sources. So this is the sources of your thiamine. And aileron layer of cereals is what is rich in thiamine. So polished rice because causes vitamin thiamine deficiency. Yes. And what are the yes. So we have seen what are the sources. And what is the RDA for this? RDA is going to be 2 to 3 milligram per day. 2 to 3 milligram per day. And why RBC transketolase level is measured in this condition? So you must first know about the enzymes that need thiamine as its cofactor. One is pyruvate dehydrogenase, alpha ketoglutarate dehydrogenase, transketolase. Okay, these are the three enzymes. So transketolase, it's an enzyme of HMP shunt pathway that needs thiamine. So this is an early manifestation. So in case of thiamine deficiency, you can estimate the thiamine activity with the help of RBC transketolase because this is considered as a early manifestation of thiamine deficiency. All right, so this is what tells us why RBC transketolase was measured. List out the enzymes dependent on this nutrient. What are the different enzymes? Again, this is the same thing. Pyruvate dehydrogenase. So TPP is the active form of this thiamine pyrophosphate. So PDH complex needs thiamine. Alpha ketoglutarate, again dehydrogenase needs thiamine. Transketolase needs thiamine. So you should know this. Yes. So the next thing is explain the biochemical basis of the clinical features in this patient. So that also we know. So what is beriberi? You know what is beriberi? The deficiency of this. The symptoms will cause anorexia, dyspepsia, heaviness, weakness and all that. And there is wet beriberi and dry beriberi. Wet beriberi in the sense you will have severe manifestations, cardiovascular manifestations like your edema, and dry beriberi will have central nervous system manifestations like your neuritis and sensory disturbances, paralysis and all that. And what is Wernicke's encephalopathy? That's an acute thiamine deficiency. Yes, it's acute thiamine deficiency. So in which case, what are the three features you will have? You have GOA. Is it not? It is global confusion, global confusion, ophthalmoplegia. Yes, ophthalmoplegia and ataxia. So these are the manifestations of Wernicke's encephalopathy. It's acute. Korsakoff syndrome is a chronic thiamine deficiency. Chronic alcoholics, you find this Korsakoff syndrome. Acute alcoholics, they do not take any food. They're starving and they're just drinking alcohol only. Then they will have Wernicke's encephalopathy. Korsakoff syndrome, there is chronic thiamine deficiency. Yes. So you will have confabulations here. Yes, making up stories for memory deficit. So confabulations here in case of Korsakoff syndrome. And what is the management of this condition? Management in the sense you just have to replenish the thiamine stores. Yes, you just have to replenish the thiamine stores. And how do you replenish? You give 50 milligrams IM for few days, like 2 to 4 days or 4 days wherein the symptoms subside. And then you will put the patient in maintenance therapy also. Right? So this is how you replenish the thiamine stores. And also you advise the patient from alcohol abstinence. Advise the patient to stop alcohol and also dietary modifications. Yes, not just the polished rice, you must have all other sources of thiamine also. You must have hand pound rice, unpolished rice. So you can just advise that. Right? So this is how you treat the thiamine deficiency. And one another point you can tell me, if an alcoholic comes with low glucose, yes, can you start glucose? Can you start IV dextrose all of a sudden? Yes, what happens when an alcoholic comes to you with low glucose value and you just give him IV dextrose? What will happen? Already this alcoholic will not have that much nutrients in them. He'll be nutritionally deficient. So he will have reduced thiamine levels. So in that case, if you give dextrose, for metabolizing this dextrose via glycolysis, your PDH complex will use thiamine, is it not? So whatever available low amounts of thiamine will get used up here, sooner. So what will happen? He will get into acute thiamine deficiency or Wernicke's encephalopathy. Right? So what should you do? It is very important to supplement thiamine first. Yes, to supplement thiamine first, followed by IV dextrose. Whenever you have an alcoholic with low glucose, supplement thiamine first and then you give dextrose infusion. Right? In that case, you can prevent the acute thiamine deficiency or Wernicke's encephalopathy. All right? Yes. So this is all about your thiamine deficiency. Yes. So I think we will, from this case 10, we will see in the next session. But we'll see few MCQs here. Okay? Is it okay for you? We'll see few MCQs. We'll just finish up faster. Okay, just give me answers for this only. First thing, is it okay for you? Is it okay? Not okay? Okay, right. So, all of the following are trioses except. So, tell me, just answer, just keep giving me answers. The first answer is maltotriose. Why is it maltotriose? All your glycerose. Yes, glycerose, dihydroxyacetone, glyceraldehyde, all are 3 carbon compounds. But maltotriose is 3 maltose together. So it is not a triose. Okay, so that's the answer here. The storage form of vitamin A in mammals is retinol. It's retinol palmitate. So to be very correct, it is retinol palmitate. Right? Yes. And Marilyn Monroe, the famous American model, actress, singer, was suffering from insomnia. Her friend introduced her to a street drug, Lily 30. Yes, and which is amobarbital. She died at the age of 36 following the intake of few lilies. Amobarbital acts by. So the final line has the question, but although all the other lines are just stories. Yes, yes. So yes, good it is. Amobarbital acts by inhibiting electron transport from the complex 1 to POQ. Yes, from complex 1 to POQ. So this is what are the other inhibitors of, this is the answer. What are the other inhibitors? Can you tell me? Rotenone. Yes, rotenone, pyrisidine A. These are other inhibitors of complex 1 and complex 2 inhibitors. It's carboxyl. Yes, complex 3 inhibitors, BAL and also antimycin A. And complex 4 inhibitors will be your cyanide, carbon monoxide and hydrogen sulfide, ide. Okay. And ATP synthase complex, FO inhibitor is very good. It is oligomycin. Yes, and ADP, ATP translocase inhibitor is what? It is atractyloside. Okay, so all ETC inhibitors are very, very important. You will definitely get. Okay, ETC inhibitors are very important. Right. Now, CPT1 is activated by all except carnitine palmitoyl transferase is activated by all except malonyl CoA. Yes, it is malonyl CoA. Is it not? Yes. So fatty acid oxidation, the rate limiting enzyme is CPT1 for fatty acid oxidation. So malonyl CoA is a inhibitor of your CPT1. All right. The next one is liver cannot utilize ketone bodies because of lack of thiolase, thioesterase, thiophorase. All confuses are being given. It is thiophorase, right? It is thiophorase. Yes, it is thiophorase. So liver forms ketone bodies, but it cannot utilize ketone bodies. Yes, very good. Next, all of the following cells are dependent on glycolysis except neurons. It is dependent on glycolysis, right? And RBCs, of course, it doesn't have mitochondria, so it is very much dependent on glycolysis. Renal medulla, yes, it is dependent on glycolysis. But what about red muscle fibers? Red muscle fibers are rich in your myoglobin and mitochondria, so it is not just dependent on glycolysis. It is the white muscle fibers that are dependent on glycolysis. All right. Yes, the next one. A neonate presented with hemolytic anemia, peripheral smear revealed that it's a case of non-spherocytic anemia. Pyruvate kinase deficiency was observed. Okay, so in pyruvate kinase deficiency, how does it cause hemolytic anemia? It causes by failure of sodium potassium ATPase pump. Okay, failure of sodium potassium ATPase pump. So that's the reason in case of pyruvate kinase deficient hemolytic anemia. All right. Yes. Next is coenzymes of PDH complex or all except. Yes, coenzymes of PDH complex are all except biotin. Is it not? You need thiamine here. Yes, you need. What are the three enzyme forms in PDH complex? It's pyruvate dehydrogenase, dihydrolipoyl transacetylase, dihydrolipoyl dehydrogenase. And coenzymes are all thiamine, lipoic acid, FAD, NAD, and CoQ. So it's very important. You have to learn about the complexes. So biotin is not a coenzyme of PDH complex. ALA synthase is an example of course, it is lyase. Ligase needs ATP. Lyase doesn't need ATP. Next is a breastfed infant. Yes, begins to vomit frequently and lose weight. Later, she is jaundiced, liver is enlarged, cataract is observed. So, whenever you find cataract in a child, it is going to be galactosemia. But don't straight away go and mark this enzyme responsible for galactosemia. Let us just read the question. She is diagnosed with classical galactosemia. The enzyme responsible for cataract is what is being asked here. Yes. What is it? It is aldose reductase. So all your galactose that is accumulated will get converted to galactitol in the lens, and that is by the enzyme aldose reductase. Okay, so the enzyme responsible for cataract is going to be aldose reductase. Yes, good. And mucopolysaccharide with galactose instead of uronic acid is what? Without uronic acid, it is keratin sulfate. Yes, without uronic acid, the mucopolysaccharide is keratin sulfate. The next is a premature child presents with infant respiratory distress syndrome. Then the lecithin is not produced. So all of the following are components of lecithin, except what are the components of lecithin? Lecithin is nothing but dipalmitoyl phosphatidylcholine, right? So you will have a glycerol backbone, and to this glycerol backbone you have, to the first carbon you have a fatty acid, that is the palmitic acid in this case of lecithin. I mean, in this case of surfactant, and the third carbon is bound to the phosphate group. So this is what is called phosphatidate, and to this a choline group is attached. So this is when you call dipalmitoyl phosphatidylcholine. So what is not present? Ceramide is not present, right? So ceramide is not a component. So ceramide has what? It has sphingosine. Yes, it has sphingosine plus fatty acid. All right. Yes. So the next one is the inner non-polar lipid core of chylomicron. So please remember, let me just tell you what are the lipids which are polar. Okay, lipids which are polar, all that which has the polar group or the OH group, alcohol group in them. What are they? Yes, phospholipid, it has a phosphate group, that is the polar group here, and monoacyl glycerol. Monoacyl glycerol, you just have a carbon fatty acid attached to only one carbon of the glycerol, so other two will have the OH group, so it can be polar. Diacyl glycerol also in the same way, and also cholesterol because it will have the OH group. But what are the non-polar lipids? Yes, what are the non-polar lipids? Cholesterol ester, because the OH group is linked to an acid. Alcohol acid forms ester linkage. So you do not have the polar group here. So it is cholesterol ester. Cholesterol ester is a non-polar group here. Also triacyl glycerol, because in the glycerol backbone, all three carbons are being filled with or attached to fatty acid. So in that case, you will not have any OH group left free. So it is also triacyl glycerol is a non-polar lipid. So now tell me what is the answer for this question. It is going to be cholesterol ester, which is the non-polar lipid core. Understood all of you? Arachidonic acid, it's a straight one-liner. It's a fatty acid in which type? Yes, 20 carbons and omega-6 fatty acid. Yes, 20 carbon and omega-6 fatty acid. Glucagon stimulates. What are the four enzymes they have given? It's glucokinase, hexokinase. Do you think it's glucokinase, hexokinase? No, they both are enzymes of your glycolysis, right? They both are enzymes of your glycolysis. So they are not stimulated by glucagon, they are stimulated by insulin, right? So in the rest of the enzymes, liver glycogen phosphorylase, muscle glycogen phosphorylase. Glycogen phosphorylase is an enzyme of glycogenolysis. Glycogenolysis gives us glucose. So anything that gives you glucose will be stimulated by glucagon, because glucagon is a hyperglycemic hormone. But liver and muscle, what do you choose? Yes, give me the answer. What do you choose? Which muscle which glycogen phosphorylase gives you blood glucose level? Gives you blood glucose. That will only be stimulated by glucagon, is it not? That's only logic, right? Yes or no? Liver or muscle? Which contributes to blood glucose? Liver only contributes to blood glucose. So only liver glycogen phosphorylase is stimulated by glucagon. Okay. Whereas muscle glycogen phosphorylase will be stimulated by epinephrine. Okay. In this also epinephrine will stimulate liver, but muscle glycogen phosphorylase is being stimulated only by epinephrine and not by glucagon. That's what is the learning point here. So this answer is going to be liver glycogen phosphorylase. Right? Yes. So the next is, which of the following is true? Yes, good, all of you. True about uncompetitive inhibition. Uncompetitive inhibition, the answer is going to be low Vmax. Yes? Yes. So quickly tell me what happens in all three. Competitive, because no question paper will be there without this enzyme inhibition. Okay. And non-competitive. Competitive is when the substrate is analogous, inhibitor is analogous to your substrate. So what happens to your Km and Vmax? Yes, you can increase the substrate concentration in case of competitive inhibition to make this Vmax constant. Okay, so your Km increases, Vmax remains constant. In non-competitive inhibition, the inhibitor will bind to another site other than the active site. Okay, inhibitor is going to bind to another site other than the active site. So here your Km is going to stay constant. Km is going to stay constant and Vmax is going to decrease, right? And in uncompetitive inhibition, what happens? Enzyme plus substrate forms an enzyme substrate complex, and my inhibitor is going to bind to this enzyme substrate complex. Okay, in that case, it is going to decrease the Km and decrease the Vmax. Okay, these are the changes in case of all these three inhibitions. Right. So in thiamine deficiency is diagnosed by estimation of what? So already we have seen it is RBC trans ketolase. And the enzyme marker for peroxisome is, yes, come on, it is catalase. Right. What are the other enzyme markers? Can you tell me? Yes, what are the other enzyme markers for nucleus? What is the enzyme marker? It can be RNase or DNase. Right. Mitochondria, you have cytochrome C oxidase or ATP synthase, right? Peroxisome, you know it is catalase. Lysosome, you have acid phosphatase, yes, and cathepsin, yes. And Golgi apparatus, you have, yes, all of you. Galactose, just recall, galactosyl transferase. All these, I've posted multiple videos also. So you also have to learn this. You would have learned so many times in your tests, in the colleges you have appearing for tests. So just recall these things. All right. So this is the marker enzymes. Okay, for endoplasmic reticulum, or you can call it microsomes. What is it? Glucose 6 phosphatase is the marker enzyme. All right. Yes. Number of ATPs produced by complete oxidation of stearic acid. Yes, tell me what is the answer for this? Stearic acid is a 18 carbon compound. So how many cycles of beta oxidation will take place? 8 cycles will take place. So 8 into 1.5 FADH2. Yes, and 8 into 2.5 of NADH. Okay, because 8 cycles it undergoes. Finally, how many acetyl CoAs do you get? You get 9 acetyl CoAs. So 9 into 10. Yeah, from 1 TCA cycle, we get 10 ATPs. Right? So when you sum up all these, what do you get? 120. They are asking you about stearic acid. It is 120 ATP. Fatty acid oxidation happens in, of course, it is mitochondria. Synthesis will happen in cytoplasm. Is it fine, all of you? Yes? So we'll wind up today's session. And again, sooner I will announce another session. Hope it was useful. Yes. Shall we end?